I'm Sam Schulman, Professor of Medicine at Department of Medicine, McMaster University, and also Director of the Clinical Thromboembolism Program there. In addition, I'm member of the ISTH Council. I would like to present to you our poster on reversal of Dabigatran-associated major bleeding with activated prothrombin complex concentrate, which was a prospective cohort study. The background here is that when we started the study, there was no antidote for Dabigatran, and although major bleeding is in most of the randomized studies less common and less serious than in patients on vitamin K antagonists, there is still a question what to do if your patient has major bleeding on Dabigatran. And there have been some case reports on activated prothrombin complex concentrate at a dose of about 50 units per kilo having a beneficial effect for these patients. Activated prothrombin complex concentrate has been used for many years in patients with hemophilia and inhibitors. And we chose the lower end of the spectrum of the doses used for those patients for safety reasons to avoid the risk of thromboembolism, and that was 50 units per kilo. And this was designed as a prospective cohort study at several centers in Canada, where they had local protocols allowing for the use of activated prothrombin complex concentrate in this situation. The patients that were eligible for the study were those who were on Dabigatran and had major bleeding according to the ISTH criteria, and it couldn't be just a drop of hemoglobin, it has to be with proof of bleeding going on. They received, according to the request of the treating physician, the dose of activated prothrombin complex concentrate, 50 units per kilo, after approval from the responsible physician on call for transfusion medicine or thrombosis service. And the main exclusion criteria were that do not resuscitate orders have been given already, because in that case it was considered no point, and that initially other hemostatic agents had been used already. The study staff were then notified that the activated prothrombin complex concentrate had been given and arrived the next day typically at the patient's bedside to obtain consent for collecting data and do a 30-day follow-up of the outcomes. So the main outcome, the effectiveness, was assessed by the treating physician, the one who observed the patient for the first several hours after infusing the activated prothrombin complex concentrate. And we provided an assessment guide that was essentially based on the one used in the K-Centra study by Sarode, published in Circulation in 2013. So the mean time from onset of bleeding to the activated prothrombin complex concentrate was 14 hours. The time from the last dose of Dabigatran to the APCC was 15.5 hours. APTT was measured in most of these patients and was prolonged in almost all of them. The median was 51 seconds. The thrombin time was measured in 12 patients, and it was prolonged in all of them. So I should say we had to stop the study at 14 cases. We had planned it for 35, but in the meantime, the antidote, idarucizumab, became approved, and it became impossible to continue recruitment. So the study stopped at 14 patients. The median dose that we gave was 44 units per kilo. The protocol, to remind you, was 50 units per kilo. But we rounded it off because we had ampules of a certain size and don't want to throw away some contents, and you don't want to use much more than planned. So effectiveness, according to the responsible physician, was good in the vast majority of patients and moderate in all, except there was one where it was assessed as poor. Now, what we did is that we also tried to compare the results with a historical cohort. And that was patients that were treated with dabigatran and had a major bleeding but did not receive activated prothrombin complex concentrate, and that was taken from the phase 3 randomized trials. And we matched patients from there, so 2 patients for each patient we had in our cohort. So 14 from ours versus 28 from the randomized trials. We matched them for age and sex and type of bleeding. So intracranial for intracranial, gastrointestinal for gastrointestinal. And you can see here that there is a trend to better outcome, more good and moderate and fewer poor than the ones in the retrospective that did not receive activated prothrombin complex concentrate. This does not reach statistical significance because of the limited number of events. Very interestingly, there was not a single thromboembolic event in our study, and you can worry when you give an activated prothrombin complex concentrate that you're causing thrombosis, but without a single event, we can say that there is no signal that this was causing thrombosis. So, in conclusion, I would say that for jurisdictions where the antidote, idarucizumab, is not available for reversal of dabigatran, this is an option, the activated prothrombin complex concentrate, to manage patients with major bleeding associated with dabigatran. Thank you.